So, good afternoon, everyone, and welcome to this webinar, which is jointly organised by the Healthy Heart Trust and the Fellowship of Postgraduate Medicine. My name's Albert Fero. I'm chair of the Healthy Heart Trust. I'm also a council member of the FPM, the Fellowship of Postgraduate Medicine. And just to tell you a little bit about this week, this is World Healthy Life Week. And the theme of this week is all around health inequalities and cardiovascular disease. We've got a series of 3 webinars during the week. Today's one, which will be on economic inequality. Wednesday, we're going to be talking about racial inequalities and heart disease. And on Thursday, we have a talk on gender and inequalities in heart disease. So quite an interesting series of webinars, which I hope people will enjoy. So you're very welcome to join not only today's, but also Wednesdays and Thursdays, all at the same time. We will also today, at the end of today's webinar, have the awards for our Art of the Heart competition. And that will be presented by my colleague John Jackson, together with Sumiti from the Healthy Heart Trust, but we'll talk more about that later. Now, just to talk about today's webinar, we're going to have some talks, one from a researcher, Dorien Kimenai, who I'll introduce in a minute, who will talk about her work on social inequalities and cardiovascular disease. And then we'll have a patient who will be talking about their lived experience. His name's Brian Scott, and I'll introduce him a little bit later. Just to let attendees know that we will take questions at the end of both presentations, but please do enter questions on the chat as we go along. So if you want to ask a question, you're very welcome to do so. Just write it in the chat. And after we've had the 2 presentations, we'll go through the questions and direct them to the relevant presenter. So I already said about the Art of the Heart Award, which is at the end. You're invited to stay until that is happening as well. And we also would encourage you, if you're attending, we encourage you to tweet about the webinar using the hashtag World Healthy Life. So please do tweet about it, or put it on X or whatever it's called these days. So that's a little bit of introduction to the week and what's going to happen today. So to start off with, I'm very pleased to introduce Dorien Kimenai, who's an epidemiologist. She is a British Heart Foundation Intermediate Research Fellow at the University of Edinburgh. Her expertise is in clinical epidemiology, healthcare data, and advanced statistical modelling. Previously, she was a cardiac perfusionist in the Netherlands, and then she undertook a master's in clinical epidemiology and a PhD at the University of Maastricht. Dorien's PhD addressed sex differences in cardiac biomarkers, and her research interests are the prevention of cardiovascular disease, cardiac biomarkers, and advanced statistical modelling. By bringing precision medicine to primary care, she aims to provide individualised strategies for the prevention of cardiovascular disease that will reduce inequalities in the provision of care. So that's her biography. She was first author on a publication in Circulation last year, which directly addressed the topic that she's going to speak about, that's to say, social inequalities and cardiovascular disease. So I'm very happy and pleased to hand over to Dorien at this point. We look forward to hearing your talk. Over to you.
Thank you, Albert, and thank you for the very nice and kind introduction. I'm going to share my screen, so I think you all can see my screen now, right?
Yes, we can.
Yes, it is really, really nice to be part of this seminar series. So thank you for the invitation. And I must say, unfortunately, I cannot be attending the sex inequalities, but I definitely will also go to the seminar about racial inequalities. So the talk of today is really focusing on socioeconomic deprivation and the role of it in the prevention of cardiovascular disease. What I would like to do today during this talk is because I'm very much aware that we have a little bit of a mixed audience. So I will first show you some insights on the relationship of socioeconomic deprivation and the relationship with cardiovascular disease. And then I will dive more into the research study that I've done last year that is focusing on current cardiovascular risk scores that are being used in clinical practice. And I would like to end with one of the projects that I'm currently working on, of which we also hope helps to reduce further the inequalities in socioeconomic deprivation. So when we first go to socioeconomic deprivation and cardiovascular disease, then it's important to understand a little bit what socioeconomic deprivation is, what the definition is. So often when people think about socioeconomic deprivation, you think more about income, but deprivation is not only relying on somebody's income. So it is also dependent on the employment status or the education level of a certain individual, access to healthcare system, access to other services like public transport or libraries. What kind of crime is in the area that the individual's living in, and housing. So when you think about deprivation and health status, then over the years, unfortunately, we become very much aware that those who are living in the most deprived areas are also doing it worse in terms of their health. So there's recently a study published which has used data from Wales, which is over almost 1 million individuals they followed up in time. And what they observed there is that what you do see on the slide is a mirror plot. So what you would hope to see in the mirror is that you do see the similar picture. But when you look at this plot, then you do see that between the most and the least deprived individuals, there it isn't similar. So the light blue is the trajectory of the individual staying healthy, and you do see that those who are living in the most deprived areas are less likely to stay healthy and are more likely to die over time. And that relationship over the years has become very clear. So also when you look at cardiovascular disease, then we do see the same pattern. So it's clearly shown that individuals who are living in the more deprived areas, and it is also shown in England that it is almost 4 times as most likely to die prematurely from cardiovascular disease. But also the development of cardiovascular disease has shown to be much higher in those individuals who are living in the most deprived areas. So what can we do about it, and what has currently been done in clinical practice? So my research area is really on the prevention of cardiovascular disease. And an important point of preventative strategies is the use of cardiovascular risk estimation systems. So the way how that works is basically that we currently are using cardiovascular risk scores that are a set of risk factors, and we can calculate the 10 years cardiovascular risk of a certain individual. Based on the results of that estimation, we target patients as those being identified as high risk, and these patients are eligible for receiving preventative therapies like lipid-lowering medications or blood pressure lowering medication use. And if you are looking at what we are currently doing with these cardiovascular risk scores, is that it is very much dependent in which country or area you're living in. So for the simplicity of the talk, I'm now only showing 3 risk scores that are being used in practice, but you should be aware that we are using much more risk scores across the world. So in Scotland, we are using the ASSIGN risk score to estimate somebody's risk. And in Europe, we are using the score 2. And in the US, it's called the pooled cohort equation that we are using. And when you think about inequalities, they have a couple of things in common, which they are all already doing. So, for example, all these risk scores are sex-specific models and tailored specifically for males and females separately. And in addition, the PCE risk score is also taking race into account in these models. So all these risk scores have similar risk factors in their model to predict somebody's risk. So that is age, cholesterol levels, somebody's blood pressure, whether you are diabetes, and also your smoking status is incorporated in these risk scores. What is different for the Scottish risk score assign as compared with the other two risk scores is that the assigned risk score also incorporates deprivation into the risk scores. And that is quite of an interesting question if you think about inequalities, because we were wondering whether socioeconomic deprivation status actually affects the performance of these three widely used primary prevention scores in clinical practice. So the assigned risk score is using a Scottish specific risk factor for to say whether the social deprivation status of a certain individual. And the way how they have defined that is basically to divide Scotland in almost 7,000 small data zones. And based on the 7 components I told you in the beginning, like income status and employment status, education, etc., they have targeted to say this data zone is deprived or this data zone is not. So they all have given these data zones a particular score. The Scottish Index of Multiple Deprivation is incorporated in the assigned risk score. So we have looked basically at 3 main groups. We have said we took the extremes. So we are looking at the most deprived individuals, the middle group, and the least deprived individuals. So what we have done is we have used a very large study, the Generation Scotland study. That is a general population study that has included, enrolled individuals between 2006 and 2011 that were presumably healthy. And we have basically made those 3 groups, the most deprived, the middle group, and the least deprived individuals. And what we have done in those individuals is estimating the risk according to these 3 risk scores, assign, score 2, and PCE. And because we had also 10-year follow-up data in this cohort available, we were actually able to not only look at what the estimation was of the risk scores, but we could look how much there was an agreement with the actual risk, and also see whether in maybe, for example, the most deprived groups, we are doing the right or the wrong thing in terms of incorporating socioeconomic deprivation status into the risk score. So what we did see across these 3 groups was in general that those who were living in the most deprived areas were definitely had worse outcomes as compared with those who were living in the least deprived areas. And that was for myocardial infarction, for stroke, cardiovascular death. And even when we were correcting for factors like sex and age, then we still did observe that those who were living in the most deprived areas had a higher likelihood of getting a cardiovascular event in the future. So the next step, what we did is for each of the risk scores, looking at what was the actual risk and the predicted risk. So for those who are not really familiar with this type of plots, basically what you see is the observed, the actual risk against the predicted probability. And in the ideal situation, risk score is predicting it correctly. And if that is the case, then you do see that the dots that you are seeing in these plots are on the diagonal line. That is basically saying we are doing the right thing. And that is the case for the assigned risk score, for the middle group. And this risk score included deprivation status into the risk score. And we do see that for both those in the most and least deprived individuals, the dots are on the diagonal line. That is really suggesting that assigned risk score seems to do the right thing and predicting accurately for also the most deprived and least deprived individuals. Another trick is to look at the ratios to divide the predicted by the observed risk. Is basically telling the same thing as the calibration plots I'm showing. And a ratio of 0 is actually that the estimated risk is in agreement with the actual risk. So now we're going to look at the risk scores that are not having deprivation status into the risk score. So by PCE score, then you clearly do see that the dots are not on the line, and that in particularly on the left plot that is showing the most deprived individuals, that we are actually under predicting the risk in the most deprived individuals. In the least deprived individuals, it seems to be the other way around, so that it seems to be that we are overestimating these individuals' risks. And we did see the similar pattern for score 2. So also this risk score has not deprivation status into the risk score. And we see the clear pattern that we are attempting to underpredict risk in those who are living in the most deprived areas. And that is recently confirmed in another Dutch study from Rolf Groenewold from the Leiden University, who also has looked in a very large group of individuals and confirmed that those who are living in the most deprived areas, that score 2 is underpredicting their risk. That is problematic. So the fact that we are not using socioeconomic deprivation status in the risk score is clearly indicating that we are creating the inequality that we just would like not to have. So it is really important that we do incorporate it. But I would also show you that even a sign isn't perfect, because what we have done at the start, it's a little bit technical, but that is basically that we updated those risk scores by using contemporary data. And when we would not do that, the assigned risk score is developed based on data from the 80s and 90s. And if you just leave it as it is and predict somebody's risk, then in the entire cohort, you basically overestimate somebody's risk. So we are currently working with the Scottish government to basically update the assigned risk score to make sure that we are using data that is in line with the current cardiovascular event rates to make sure that we don't disadvantage anybody. So yeah, the study in itself clearly showed that those risk scores that don't incorporate socioeconomic deprivation as a risk factor, that leads to inequalities, and that could have also consequences for those individuals to target them at high risk, and also for the preventative strategies that you have in terms of preventative medication use. And it does show that incorporating socioeconomic deprivation also leads to the equality in terms of predicting somebody's cardiovascular risk. I would like to end my talk with a project where we're currently working on, and that is creating the data infrastructure to enable pragmatic clinical trials. And the reason why I would like to highlight this is because for this project, I work with Datalog. And Datalog is a data service that is developed in partnership with the NHS Lothian and the University of Edinburgh. And it covers social healthcare data and healthcare data from the southeast region in Scotland. And I find it we currently, as research from the University of Edinburgh, are using this data, but the reason why I would like to highlight Datalog is that every researcher that has an important research question can use this data. So it is not only restricted to the researchers from the University of Edinburgh. But the project that we currently started is that we are currently building a registry where we're going to look back in time from 2009 onwards. We are using electronic healthcare records from primary and secondary care. We're going to examine inequalities, looking at socioeconomic status, but also sex and ethnicity and age inequalities, to see whether in terms of risk assessments, how we are currently doing it, and also if that has changed over the time. And the second part of this project is creating the data structure for data-enabled clinical trials of novel interventions in the primary preventative area. And an important component that we have built is also the co-design intervention, because often as a researcher, we think that we think of brilliant solutions, and in the reality, those solutions often are not feasible, or not the persons who are actually going to work with those tools is just not working for them. So the co-design intervention part is really important for getting it right, that what we test and implement in our clinical practice is really useful and reduce inequalities further. I would like to stop my presentation here, but I would like to thank the entire team I'm working in, and specifically also mention Leah for all her hard work in the statistical analysis that she has done with me, and Anup Shah, who unfortunately was not able to be here today, but I've worked a lot with him on the projects I've been showing today. Thank you very much. I'm happy to answer any questions.
Great. Thank you very much indeed, Dorien. That was fascinating stuff. We won't take questions at this point, although, again, I'll just encourage the audience to put any questions into the chat, and we'll take them after the next talk. And I'm delighted to introduce Brian Scott, who's going to be our next presenter. And Brian is going to be talking from the point of view of a patient, although he used to be a cardiology nurse, but no longer. And he's going to talk with the title, "The Cost of Living Crisis is Killing Me." So, Brian, I'll hand over to you, please. Thank you.
Yes, thank you, Albert, and thank you, everyone, for your invite to speak today. As Albert said, my name is Brian Scott. I live in Glasgow. I'm an ex-cardiology nurse, and I'm been a campaigner, an anti-poverty campaigner with the Poverty Truth community in Glasgow for 5 years, and with the Apple Collective, which stands for Addressing Poverty Through Lived Experience, for the last 2 years, travelling all over the UK. So, why do I feel qualified to speak about poverty and the link to ill health? Well, as a child, I grew up and I still live in an area of Glasgow called Russell Park, which is Dorien highlighted in their Scottish Index of Multiple Deprivation as an SIMD1 area, the most deprived. As I said, I grew up in poverty. My father died when I was 11 years old, and my mother had to bring up myself and an older sister, my older siblings being married by that stage, but we lived in a lot of poverty. As an adult, as I said, I worked as a nurse, and I had an injury at work, which meant that I could no longer work as a nurse. I was medically discharged, and I now live on state disability benefits, PIP and ESA. I've also, like I said, been a campaigner in anti-poverty groups for the last 5 years, and I have seen poverty all over the UK. And there's lots of similarities no matter where you go, and causes, etc. And I hope that my talk can put into context the presentation that Dorien has just given with the statistical data. So what are the causes of poverty? Unemployment, disability, illness, addiction issues, marital breakup, debt, the minimum wage, 0 hours contracts, and the gig economy. These are all the major causes of poverty that I've experienced. And when you live in poverty, there are lots of issues, especially ones that can affect your health. And I've experienced that, as well as the injury I incurred when I was working as a nurse. In the last year, I have been diagnosed with esophageal cancer. And I've been very lucky and very grateful to the NHS, where they removed the cancer and have given me a second chance of life. And I am so grateful to all the medical staff in the NHS for giving me this opportunity to carry on. But esophageal cancer is something I never thought I would have. I have never smoked in my life. I don't drink. Yes, I eat the wrong foods. But why do you still get illnesses when you do all that? Well, when you're in poverty, the poverty itself can affect you, and all this is to go with it. The stress of everyday life can cause you to be ill. And unfortunately, I've had dealings with the Department of Work and Pensions where the stress of that can cause you illness. I say that if you don't have a mental health issue, before dealing with the system of the DWP, you should know have. I remember one occasion which I was an ex-nurse who's used to dealing with wards of patients and dealing with emergency situations. And I went in to fill in a form for the disability benefits. And I was under so much stress that I broke down in tears. I couldn't manage it. There, I was just doing care plans, filling out activities of daily living, but I couldn't fill out a form. And that's how stressful the DWP can get you. And also you're under constant assessment. When you're in poverty, you have no control over your life. Decisions made by politicians and policymakers hundreds of miles away can have a detrimental effect on your life. In fact, within the anti-poverty movement, there's a syndrome called brown envelope syndrome, because that's the type of envelope the DWP send out to inform you of any updates to your benefits. And you dread that brown envelope coming through your door, because the decision made by the politicians can have such an effect in your life. We've all read stories about people who have had their universal credit changed, and within a blink of an eye, they can lose several £100s a month, which means that they are put into even worse financial straits. If you're in debt and you go to a debt management agency, they'll not always control your debt, and you're subject to the harassment from your creditors who won't payment. I was in that position when I was first medically discharged, and I remember one day that one creditor continually phoned me up to 10 times a day. When you're dealing with that, the stress is so impossible to actually to describe to someone. Also, there's a lot of shame and lack of dignity that comes when you're in debt, that adds to your mental stress. I personally felt as if I was constantly judged, that I was worthless. I lost a job which I loved, and now I was nothing. And the shame and lack of dignity that comes with that is indescribable. And finally, what we're talking about today, the cost of living crisis. Rising food prices, rising energy prices, rising rents, in fact, rising everything, means that for a lot of people, even those in employment are living from hand to mouth, and they cannot make any decisions because they don't know if they'll have enough money at the end of the month. So I've described some of the stressors. So how do these actually affect you? Stress is a big one, and we know that health does not work in isolation. If you have mental health issues like stress, they'll manifest in a physical illness as well. But I'd like to look at some of the factors that we know lead to coronary heart disease. I'll start with food. Again, when you're in poverty, you're limited with choice. What can you afford to buy? Unfortunately, most of the foodstuffs that are cheap are the ones that are unhealthy. Also, quite a lot of the buy one, get one free deals that are available in supermarkets, again, are often unhealthy foods. In Postle Park, I am fortunate where there's a local supermarket called Lidl's, which means you can get the cheaper food and you can work within a budget. But again, the cost of living crisis affects what you can buy. The current rate of inflation is roughly about 7%, but food, and there's been research in the last few months that have shown it, has not gone up by 7%, has gone up by 30 to 40%, especially in the basics. Some supermarkets have even started restricting the amount of food you can buy with their basic ranges. You're limited to 1 or 2 purchases, which if you've got a big family is not very use. But like I said, in Postle Park, I'm lucky where we have that local supermarket. If that was to close down, the nearest supermarket to me is, the way I walk, is about 1.5 hours away, if I could walk. But if you can't walk, then you've got to buy tickets. You need to go and use public transport, which for me again is 2 bus journeys, which is a £5 all day ticket in Glasgow. If I couldn't travel by bus for whatever reason, then you've got no option then but to go by taxi, which can be £20 for both the outward and inward journey. If you're in a tight budget, that £5 or £20 is coming off your food budget, which means you're going to have to lose something on your shopping list. Also, as well, there's a phrase called the poverty premium, where it, in simple terms, it costs money to be in poverty. For example, if you're on the meter system, where you pay up front for the electrical charges, like the electrical card, you have no choice but to be in the highest tariff available. Also, if you run out of electricity and you have no money in your card and you have to press the emergency button, you're an even higher tariff. I know of people who have been offered the opportunity to go on a smart meter from the prepayment meter, and they've been waiting up to 2 to 3 years for the electricity company to come and change them. And all that time, they're paying the highest tariff. They have no choice. Also, getting back to food. If Lidl's closes down, like I said, and I couldn't afford to travel to my local supermarket, I would have to shop locally. Unfortunately, the prices in the local shops are 50 pence to £1 higher than you would pay in a supermarket. For example, a loaf of bread from Lidl's costs 75p. If I was to go to the local shop just down the road from me, that same loaf would be £1.75. It's a poverty premium in action. So that is one of the big factors that can cause stress and difficulties in your life. We all know that smoking, alcohol, and drugs are all factors that can lead to coronary heart disease. And knowing all the dangers as you do now for things like smoking, why do people still do it? Well, in my experience, people use things like smoking as a coping device. Growing up, I have always got a memory of every member of my family smoking. That's the adults. Both me and my sister, who were the youngest in the family, we have never smoked. Yet, I have been diagnosed with a cancer which has been linked to smoking, so I've never smoked in my life. My older sister, who was growing up with me in the house, she has never smoked, yet she died with an illness called pulmonary hypertension, which is very rare. Again, is it linked to smoking? I always have memories of my mother, and this is a very good example of how smoking is used as a coping strategy, is that she would give up eating just to have a packet of cigarettes. The smoking was a really important thing in her life because that's what she used as a coping mechanism. I recently read a study where, and it was a Scottish study, where the participants put in quotes where they kind of reinforce what I've just said. Smoking is such an important thing in their life. It adds extra stress to them because the cost of smoking is going up and up and up, but they won't give it up because that's what gets them through the day. So we know that leads to coronary heart problems, and I'd say the majority of middle-aged people that I know in Postle Park have some form of respiratory disease, mainly COPD. Alcohol, again, it's a coping mechanism, and it is a problem in Postle Park. You usually find if you've got an alcohol problem, you smoke as well. And this is compounded in Scotland because we have the Minimum Pricing Act in alcohol, which is targeted at the cheap and powerful alcohols like the White Lightnings and the cheap ciders, etc. But if you're using it as a coping mechanism, you'll find that money from somewhere. But funny enough, the one form of alcohol, especially amongst the Scottish youth, which is causing a problem, doesn't have this Minimal Pricing Act enforced upon it, Buckfast, which says the drink of choice for teenagers in Scotland, which you can see it's going to lead on to extra problems as you go into adulthood. Then drugs. Drugs are also a problem that lead to coronary problems in my experience. Postle Park in the 80s and 90s was known as the drug capital of Scotland. It's not so bad now, but there is still a drug problem. And my experience in cardiology, when I was a cardiac nurse, I did the cardiac rotation, which meant that I had experience in coronary care, cardiothoracic, and my last placement was in the cardiac catheterization lab. When I first started in the cath lab, the average patient who was going through an angioplasty and an angiogram was a middle-aged white male in their 50s and 60s. But I noticed over the years, the demographics of the patients changed. And you're regularly seeing, again, white males, but they were in their 30s. And when you were talking to them, they admitted that the majority of them were drug users, and they would use the softer drugs. If they were on hard drugs, they would use the softer drugs mixed with tobacco in a roll-up to get them by. Or if they were just social drug users, occasional drug users, again, they would roll up the drugs mixed with tobacco in a roll-up cigarette. And quite a lot of times they didn't use a filter. And just in my own opinion, that added to them coming in with coronary problems. So, what do we do about it? Well, unfortunately, there's no easy answer and there's no quick fix. And it'll take us all working together to try and get some change. One of my suggestions would be, and the government started to do it, but it's kind of gone quiet now, was they were going to have a committee look into what is the pricing structure supermarkets use, especially in basic foods like bread, pasta, food oils, etc., that they are rising above the rate of inflation by so much. How can they justify it? Also, can we encourage the supermarkets to make more of their buy one, get one free deals, be more specific to healthy foods to encourage people? If I had a choice, I buy unhealthy foods because quite a lot of the times it's all I can afford. But if I had a choice between buying a healthy food and making a healthy meal or buying a tin of something, then I would go and make it because you can get more out of it, it lasts longer. But unlike Lee Anderson said, you can't make a meal for 30p. You can't even buy a chocolate bar for 30p nowadays. Also, I would ask medical practitioners to be a bit more sympathetic to people and not so quick to judge. There's multiple factors behind why someone can present to you with a coronary heart condition. It could be lifestyle choices. It could be familial background issues. But don't be so quick to judge. Because when you're under stress and in poverty, that packet of cigarettes that gets you through the day is so important to you. So I would like to thank you for your time. I would like to thank you for listening to me. And I did a blog for the Healthy Heart Trust, which goes into a lot more detail, which I am more than happy to make available to you through the Healthy Heart Trust. And I'd be happy to answer your questions at the end of the webinar. But again, thank you for giving me this opportunity to speak to you. Thank you.
Brian, thank you very much. That was very moving and insightful. So thank you very much for that. Brian, could you activate your video if that's all right? And Dorien, I see you've activated yours. That's great. You're muted, Brian.
Sorry, I thought I had it on. I apologise. I was too taken with speaking, so I must have switched itself off.
No, it's all right. No, you're obviously very deeply into what you wanted to say, which was very very interesting. But thank you. Yeah, so we'll take some questions now, and there's a couple in there. I'll start off with you, Brian, actually. And there's a question here, which I think you kind of partly addressed. Says, thank you for a very moving description of your lived experience. Can I ask you if you can point to one or two things that somebody in your situation could do to help them cope?
One of the good things is peer support. There's always people around you in the same situation. In my own experience, I thought I was the only one that was going through it. And especially with my medical condition, where the injury I had has left me in chronic pain too. But meeting people who have similar experiences to you is such a big thing in your life, knowing you're not alone. And one of the motivators for me doing this kind of project and doing anti-poverty campaigning is I've always got the image of someone who's maybe just lost their job, who's having to deal with the DWP and everything that goes with losing your job, who's at home and thinks, I'm the only one going through this. What do I do? How do I get through this? I can't cope. But letting them know we've been there. We understand what you're going through. We can understand the issues you're having to deal with. Come and talk to us. Even if it's just for 5 minutes, even if it's just for a cup of tea and a chat, there's groups locally that can help you. And there is help out there, but don't tackle it on your own because it is too big for you to deal with on your own. And having people there to walk with you and support you is one of the greatest things you can have in your life.
And if I could just extend on that, I mean, is it always, I mean, you can imagine there are some people who have that network, those connections where they could do that, and others who are probably in quite an isolated situation who don't really, are not really able to reach out to others or don't know how to reach out to others. So presumably it's not always so easy to do that.
It's trying to make use of your community resources. Say you're having a drop-in. There's community cafes where I stay. So say you're having a drop-in. Don't just advertise them in the local areas like so the library or the local community centre. One of the most common places people go to is the doctor's surgery, put it up in the GP notice board, put it in the post office. The local shops are more than happy to put details of local events in their window. So you're trying to think about where are the places that people are going. You can't cover everything 100%, unfortunately. I wish you could. But in your local area is to kind of maybe think outside the box a little bit. And like I say, if most people go to a local GP surgery or to see the practice nurse, to see their GP, to see the dentist, whatever, you make use of all the notice boards everywhere.
Yeah. Thank you. Thank you. Dorien, there's a question for you as well. You talked about how the deprivation measure seems to work well for the assigned model in Scotland. And the question was, how easy would it be for other territories to develop and incorporate similar deprivation scores into their modelling?
Yeah, that's a good question, actually. And first of all, Brian, thank you so much for your presentation. It's always really good to hear this kind of story. So thank you for that. So John, you're spot on with that question, actually, because when you think about the national scores that are being developed, for example, ASSIGN, but also QRISK-3 is the English version. They all have a national social deprivation score that has been developed and that it is relatively easily to incorporate into a risk score. But for score 2, for example, that's more problematic because that is a risk score that's being developed for the entire Europe. And I think it has to say that there are a couple of advantages of score 2, really, that we are using much more data in terms of the methods they are applying. It's really advanced, but there are a couple of disadvantages too. One of them is that it is mainly based on white individuals, which I think is really problematic if you think about inequalities. I think they've not developed really a risk score for other ethnicities. But the other one is also social deprivation. It's much more difficult to incorporate. But one of the things they could do, for example, they've now developed score 2 for low risk and high risk countries. And I think what they need to do is go a couple of steps further, and that they make it more region specific, because then you are allowed again to also incorporate your differences between economic subgroups. So I think only the risk score 2 for low risk and high risk, I think that is still too simplistic with what the reality has been. So that are kind of approaches to use national or regional mortality data to make it more tailored to the specific subgroup where you would like to estimate the risk of an individual.
And kind of related to this, Dorien, then, so all of these scores are based on epidemiological data and so forth. So is it, you talked about how the scores can under or overestimate the risk. So is it that the demographics of the populations that are being used in these data, are they the wrong populations, or are they a selective population? Are they not representing the true population that is trying to be addressed here?
The problem more is that the relationship, for example, with age and cardiovascular disease is never going to change. So the relationship that is captured in that risk equation, that basically doesn't change. So you can use data that is pretty old. The problem comes in that in terms of events, 20 years ago, it was much higher as compared with the actual cardiovascular events risk now. And when you're using data from the 80s and the 90s, part of the equation is not only the relationship between the risk factor and the event, but part is also just the baseline hazard that population has. And if you don't update that to the data, which we are currently in, the time frame we are in, then you're always doing the wrong thing. And what Q-Risk3 is really nicely doing, because all these risk scores have their own disadvantages, but also advantages. But Q-Risk is really clever by saying we update those risk scores every year because we would like to keep it up to date to what the current risk should be. So I think Q-Risk is a very nice example of how other risk scores maybe should incorporate into their systems as well, instead of saying we develop a risk model that works perfectly and then we never touch it again. That's, I think, not the right approach. No.
Thank you. And there's another question. So we're very familiar with traditional risk factors, you know, cholesterol and blood pressure, smoking, etc. Can you give us an idea of how important differences in or social deprivation indices, how important that is in relation to the more recognized risk factors? Is it a fairly minor component or is it fairly major? So it's a difficult question, but can you give us a bit of an idea of how to quantify it in comparison with the risk factors we know about?
So, for example, age is the strongest one, but the problem is you cannot change age, right? And we would like to develop also systems of where we can basically modify somebody's risk instead of only telling you are at high risk. We do see that socioeconomic deprivation seems to be more strongly associated in men with cardiovascular events than in women. But that was an observation we have made, but we are not really understanding why that seems to be the case. So that is kind of an interesting to dive deeper into what the explanations for that can be. But yeah, it is still the case that if you don't factor it in, that the normal risk score doesn't cover it. So you do see then the inequalities coming back.
Thank you. And Brian, you've got your hand up there.
Yeah, it's just to follow on from what Dorien is saying. It's been started to be noticed that, to start with, the poverty doesn't just affect individual, it affects the whole family. And it's starting to be noticed that poverty is having a detrimental effect on children, especially, and families where poverty is an issue. You had the GRF, the Joseph Rowntree Foundation report just last week that showed that the levels of children in poverty is actually rising. I think it was 10 years ago that 1 in 5 children were technically classed as in poverty. It's now 1 in 4 children are in poverty. And if trends continue as they are, then by 2030, 1 in 3 children in the UK will be in poverty. And linked in with all the issues that children are having to deal with due to COVID and the rise in mental health issues in children and the lack of services, unfortunately, because funding is not there, poverty has a detrimental effect on children and their mental health. And my concern would be, is that laying the foundations for ill health, especially coronary ill health later in life? Because it could lead them down to addictions again. Will they take up smoking as a parent instead? Will they take up drinking alcohol, etc., etc.? And it's a repeated cycle. And also there's the unknowables. And Glasgow was known as the sixth man of Europe when it came to coronary care. It was the myocardial infarction capital at one point. And there's a thing known as the Glasgow effect. Well, why, when you compare Glasgow, men in Glasgow, with similar types of places such as Liverpool and Belfast with the same industrial history, same unemployment history, etc., why are the health outcomes for men in Glasgow so much worse when you compare to these 2 other places? And at this present time, we still don't know. Again, it's one of these we need to look into, but people have been looking into it for decades, and there's still no definitive answer.
I think it's also important, Brian, you are really right that it's important that we also identify that we acknowledge that the problem already starts at a very young age. So the first study I basically presented today, I only showed the 7-year-olds, but even the individuals who are 10 years old, we do see the inequality already there and then. And that means that my risk score, where you basically start preventing somebody's risk, is only targeted for the more adult individuals. So I think we should also really targeting on reducing the inequalities, not only in adults but also in the younger individuals. Yeah.
So there are some important points there. So thank you both. I think there's an important point that a lot of this affects and impacts children from a young age, and so inequality is important from an early age. And secondly, although I was saying how important is inequality compared with traditional risk factors, there's actually quite a close link there anyway, because of the unhealthy behaviours that you're likely to indulge in, including smoking, eating poorly, and so forth. So they're not sort of totally separate things, not totally separate risk factors. They're intertwined there. So I think there's some important points to take away there. Another point for Brian, if I may, you talked very nicely about behaviours that may lead to coronary disease, including smoking, and why that might be more prevalent in people who are in a more deprived situation, poor diet, and so forth. What about access to healthcare? Do you think that that's an important issue for those who are economically deprived?
Yeah, as part of the Apple Collective, recently I was a peer researcher that started out as comparing access to primary care prior to the COVID lockdown compared to now. And as the research developed, it brought in the digital divide. As in, nowadays, there's a whole process you have to go through to have an appointment with your GP. And if you have to go through either using a computer system, where quite a lot of GP surgeries use the diary appointment system, where you go online, check the diary, see if there's an appointment for you, and you take the first one available. But what if you don't have a digital device such as a laptop, a mobile phone, a tablet, whatever, or in the case, and it's usually in older people, they may have a mobile phone, but it's not a smartphone, so it doesn't have access to the internet. How can you access these GP services? Also, you may have a digital a digital device, but what if you can't afford the internet? Or you've got very low usage for the mobile internet. You don't have an awful lot of capacity because you can't afford it. These also can cause lack of access to services. Also, what we found in the study, and this was right across the UK, because it was getting difficult to access GP surgeries, quite a lot of people weren't bothering, because they thought, what's the point? Because we have to go through the gatekeeper, which is usually a receptionist, who then takes your details, and you've got to worry, is it the receptionist taking down the information correctly, which is then passed on to the GP, who makes a decision whether they call up the patient. Then, depending on the phone conversation, do they go forward to an appointment? Going through that system, a lot of people were just saying, it's not worth it. I've got better things to do with my time. So there's a lot of issues regarding access to health services. And it's going to my worry again is that because of the various issues that are going on, there are going to be misdiagnoses and missed diagnoses. Can I give an example from my own life? As I said in my piece, I was diagnosed with esophageal cancer. I was originally diagnosed with heartburn, and I was sent for scope. And when they put the scope down my throat, I was awake, and it was with throat spray. I was in so much distress and discomfort I couldn't carry on. I was then sent for an X-ray. X-ray didn't show anything. So it's progressed onto GERD. It's pretty bad heartburn, but it's just heartburn. But I knew myself with the pain I was experiencing and the way it was kind of going through my body, that it wasn't heartburn. I was lucky enough to have the medical knowledge and the confidence to keep at my GP until I was sent for a scope again, where I was sedated. And that's when I discovered I had esophageal cancer. Unfortunately, the vast majority of the public in that situation, because they don't have that medical knowledge, and most of them, it's the white coat syndrome, where the doctor says it's this, so it's this. They wouldn't question it. And by the time they may be diagnosed, it could be too late. It could have progressed to stage 3 or stage 4. And my concern is that is happening at the moment. And there's a lot of misdiagnoses going on.
Yeah. And that may be more likely if you're in a deprived sort of situation. Indeed. Thank you. I can't see any more questions online. Are there any last questions before we close this this webinar? No, I think we're probably done. In which case, it just remains for me to say thank you to Brian and to Dorien. Thank you both very much indeed for 2 outstanding talks, and thank you for contributing to this webinar. And thank you to the attendees as well for joining. I hope you found it interesting as I have.